All right. Happy Thursday, everybody. Welcome to another version of VMR. Unlike most Thursdays, which is a first for many, today there is a first for none. It's the return of the legendary Masa to get another case under her belt simply because of how much of a shining light she is internally. It's also the return of a seasoned case presenter, Shreya. It's also the veteran scribing of Aaron. And I would say, actually, yeah, there he is. I was worried that Vinny wasn't here, but I see him. I was so happy to see that we have our dearest Vinny back in the in the teaching point seat. And yes, see me, I'm here as always. There's no return. There's no fanfare. It's nothing but boring me hanging out with you all, and I'm very, very excited for this all. Um, the compacted intro is for two reasons. One, those on YouTube who may be spared 5 minutes of fast forwarding, but also because I have to leave a little bit early today. So let me hand the mic to everybody to say hello. First with Masa, and then Shreya, and then Aaron, and then Vinny, and then we will rock and roll.
Hey everyone, it's Masa, and I'm excited for today's case, though a little nervous, but I'm sure it'll be as sweet as Shreya is.
Hi
Yeah,
everyone.
hi
Oh,
everyone. Hi everyone. I'm Shreya Upadhyay. I'm a medical graduate from Nepal. Yeah, I have brought a sweet case for everyone, and I hope it brings some warmth in this cold winter for everyone.
Hey everybody, I'm facing trouble to open my camera here, but I'm here in the background, so super excited for the case today and for massive discussion. So let's rock it.
I'm gonna keep up the theme of interrupting Aaron just for the fun of it. But Aaron, Aaron, make a mic to you to say hello.
hi everyone. I'm Aaron. I'm going to be scribing today. I'm excited for Shreya's case and excited for Masa and Rabih's discussion.
Team, we're coming to you live from all the way everywhere between Hawaii and Nepal, which is really, really cool. I think everybody else is sandwiched between those two parts of the world. Yeah, Shreya, whenever you're ready, take it away.
Okay. So we have a 80-year-old female presenting with abdominal pain for 3 months, altered bowel habits for 1 month, and bilateral lower limb swelling for 20 days. And I'm gonna stop here and listen to your thoughts.
But Masa, I'll be very transparent with you. When this happens in real life and you're getting this information from the patient in the first 30 seconds, you really have to make an educated guess about where you're going to start. This is too much, honestly. So I think there's a lot to empower people about where are you inclined to start in the belly or the legs, or what is your mind doing? Not necessarily in detail, but just where to start. What do you
I
think?
think since the abdominal pain has been going on for a while, maybe
Yeah.
this is like something we can have on the side, but definitely like
Yeah.
tie in a bit.
Yeah.
But probably focus on the bilateral leg swelling.
Yeah.
It's it's not very acute, but
Right.
it's something that can like affect. I mean, we always talk about the three organs that it affects, which is the heart, the kidney, and the liver. So, yeah, I would focus on the bilateral leg swelling, but also like think of the abdominal pain as like an associated symptom.
I agree with you. You know, one thing that you just made me realize that I don't think we've ever taught or vocalized before is the concept of being able to make progress quickly. And if you happen to have a specific data point that you can take further effortlessly, you'll probably take that to your advantage. And if I'm imagining standing next to you taking care of this patient together, how much time we would need to understand her abdominal pain with a good exam, labs, maybe even imaging, in stark contrast to how much time we would need to understand her leg swelling. The first is we would be able to validate whether it's true or not, and then be able to study the JVP, whether she has cirrhosis, whether she has signs of kidney dysfunction. So I think also the ability to actually make progress very quickly is a reason to is another reason why I, like you, am focusing on the leg swelling. And you shared with us an outstanding approach, beginning with the three organs. So if we keep those three organs front and center, how are you then incorporating the abdominal pain? Does that help you prioritize one over the other?
I think does it help? Maybe more the liver,
Yeah.
but overall, because any of the three can cause ascites.
Yeah.
but maybe more commonly the liver.
Yeah, I completely agree with you. I think at first glance, you're like the liver's in the belly, it takes up a lot of space. But when you study it in more detail, you're like, actually, no, I think all of them can fit. I think the truth is that patients who present with abdominal pain and who have lower extremity edema, we would probably make the educated inference that the cause of the abdominal pain is from ascites because we see fluid in the legs. And I think we have a very powerful way of clarifying the ascites with testing and imaging and whatnot. So I think all that I would be asking in this patient is the leg swelling visible or not? Is it a real serious problem? And does it help us simplify the abdomen into assuming the abdominal pain has a component of ascites related to it? And I think we can easily verify these hypotheses with a good physical exam and a POCUS. And so my mental model is what's in the belly? Is it fluid or not? And if it is fluid, then I think we have updated our problem significantly. We went from abdominal pain to ascites in the belly. If it's not fluid, I think it becomes an interesting thing to try to say, well, how do we connect a non-fluid process in the belly with a fluid process in the legs? So yeah, I'm right there with you. I think we should start with analyzing the legs and being, oh my gosh, Tanduna. She's using the garbage disposal, which is very distracting. Um, um, yeah, so I'm starting with the legs like you, and then I'm really curious what's happening in the belly. And I think the assumption is it's probably fluid, but let's see what sweet surprises Shreya has waiting for us.
Absolutely a wonderful discussion. So yeah, since 3 months, she's having dull aching and non-radiating epigastric pain, not relieved by medications. It's associated with occasional nausea and vomiting as well. Before, she used to defecate with Isfagol, which is laxative, regularly, but now it's been harder for her. She also noticed bilateral limb swelling, which is slowly progressing since 20 days. And now, since around 1 week, she feels her face being puffy as well. There's no history of fever, headache, abdominal distension, hematemesis, cough, chest pain, shortness of breath, orthopnea, melena, and oliguria. In the past, she has NSTEMI with reduced ejection fraction of 40%. She also has history of atrial fibrillation, gastric ulcers, and hypertension. Her medications are amiodarone, apixaban, losartan, and metoprolol. Uh, but she is not taking her medications regularly. She does not smoke and does not drink alcohol. She does not walk and stays at home. Her son is her primary caretaker and she's from Nepal. And I'm going to take a brief pause for the discussion.
Shreya, this is an absolutely incredible presentation, so crystal clear. You know, the sequence of the events and the clarity of the events in the HPI is so palpable. You can literally really gives us a very clear understanding of what's happening. Aaron, kudos to you for keeping up. There's a lot of data here. Let us know if you have any lingering questions. But I think the only thing that I caught that might be important is that I think she's on amlodipine. Is that right, Shreya? Or did I
I'm sorry,
misheard?
she's on amiodarone.
Amiodarone. Okay.
No,
Sorry.
yeah,
Amazing.
amiodarone and losartan. Yeah.
Aaron, I don't even have the job of scribing, and yet you're capturing the data better than I am. Nice job, my friend.
Uh, I can say that again, medications if you
Yeah,
want.
is the list that you're seeing on the whiteboard accurate, Shreya, or do you have any changes to it?
Uh, uh,
Amiodarone,
okay, let me
losartan,
see.
apixaban,
Yeah, metoprolol as well.
and
But her
metoprolol.
medication compliance was pretty poor.
I see. All right, Masa, see, I got you an extra minute to think. I'm curious, so what thoughts are crossing your mind now?
Oh my God. Okay. So I'm gonna take this kind of step by step because it gets a bit overwhelming, but maybe with the epigastric pain, if I'm thinking of the structures there, we have the esophagus, which and the stomach. So she, if I remember correctly, she did have some ulcers. Um, so yeah, I would think of that. And then also we have the pancreas there. I'm not sure how it relates, but I would just think of that. And then the fact her face is getting puffy now. It's not. I was thinking first about something like nephrotic syndrome, but she doesn't seem to have any oliguria. But yeah, that's like a thought that I had. Um, she did have a history of NSTEMI and MI, so and she does have a heart failure with reduced ejection fraction, and she's non-compliant with her medications. So would also like think of the heart um as a focus. So I am I'm wondering how I would move on from here. I think I need your help.
I don't think so. I'm gonna actually uh, reflect back with you, but I don't want to make any assumptions. So reflexively, did you think your mind made more progress with studying the epigastric pain, or your mind made more progress by studying the facial edema? Just reflexively. What helped you more?
I would say the facial edema.
Yeah, exactly. I think part of clinical reasoning is realizing, again, with this theme, Shreya is allowing us to bring up this theme of what do you study? Leg swelling, better than abdominal pain. Abdominal pain, we've changed it to epigastric pain, but yet we're finding the swelling aspect is way more productive. Because the swelling aspect, I think, is so demonstrable that you can take it to the bank and really invest in it. And of course, you can exonerate if you just take one look at the patient and you see no facial swelling and no leg edema. You're like, maybe she feels a little tight, but there's nothing there. And so, gosh, what does the presence of facial edema do? If you take those three organs, Masa, and ask yourselves which one of those three organs can present with facial edema, I think the probability of nephrotic syndrome really skyrockets. And the premise there is, unless you're living upside down, where facial edema can then happen from gravity dependence, it gives you an insight into the pathophysiological process that's resulting in the edema. And I can take these headphones on now, thankfully, because the chaos in the kitchen is resolved. Um, so, um, Maza, if we just go back to the pathophysiology of the edema in heart failure, the pathophysiology of edema in heart failure is simply venous hypertension. And there's higher pressures in the veins, the more anti-gravity you are. So all the way at the bottom in your legs, highest pressure. That's because they have to fight against the gravitational pull to go all the way back up. And so those are the places that tend to get more edema. And if you lie down in bed, your buttock becomes the most dependent process where gravitational forces are at play. So the edema and heart failure is not symmetric, it's gravity dependent. The edema in liver disease is usually minimal compared to the abdominal distension and is also gravity dependent for very complicated mechanisms. If you study kidney disease, you'll realize that the edema in most instances of kidney disease is actually also gravity dependent. But if you study in detail the schemas that we have on the website, Masa, you'll see that nephrotic syndrome gets a little bit of a special mention in the realm of kidney disease because nephrotic syndrome actually isn't just a kidney disease. What's happening in nephrotic syndrome is that there is diffuse vascular endocapillary leak, and every single capillary in the body is oozing a little bit. It just so happens that the main capillaries that are oozing are actually in the glomerulus. And those capillaries leak albumin into the urine, and that's why we diagnose somebody with nephrotic syndrome. And so, why is there a facial edema in nephrotic syndrome? It's because no capillary is spared from being leaked. And so, it is an example of what is called a systemic capillary leak syndrome. But unlike the rare and esoteric systemic capillary leak syndromes, nephrotic syndrome is probably best characterized as a systemic capillary leak syndrome with disproportional effects on the glomerular capillaries, which is why it's distinguished from the other capillary leak syndromes. And hint, you should check out the most recent schema episode featuring Noah, who I think is here, and the schema episode colleagues. Yeah, so that's why the facial edema is powerful because it makes you say, wait, hold on, you're swelling, but you're swelling in a non-gravity dependent manner. I bet your vessels are leaking. And the most common capillary leak syndrome is nephrotic syndrome. There's also some other mechanisms that can cause a non-gravity dependent edema, and that's through uh, um, uh, glycosaminoglycan deposition through thyroid disease. So for me, Masa, I'm updating this problem representation, and I'm worried that the patient is more on the spectrum of anasarca than they are on the spectrum of gravity-dependent edema, and that really has us in a completely different sphere. I wouldn't get too esoteric about it too quickly without laying hands on the patient and making sure these findings are true. And I think the question remains, how can we take advantage of the fact that she's having other symptoms to help us make progress on her swelling? And the tension, Masa, is that whenever somebody has fluid overload anywhere can cause organs to be unhappy. So all this abdominal signal we have may be actually clues outside the vessels that can help us figure out what's going on, but it may be simply tense, tight bowel walls and tense, tight ascites, which doesn't allow us to make progress on the actual diagnostics of the problem. It may help us understand how bad this is, but may not offer any more specificity. So I think one simple question is all of this swelling everywhere? Or is there swelling somewhere with another parallel problem outside the blood vessels that can give us a clue as to what's going on? And right now we know there's swelling, so we can clarify that more. And it remains to be seen if the other symptoms are an additional clue or just a marker of where else there is swelling. And so I think an exam will be really, really key in this patient. All right,
Sounds good.
Shreya,
And
right to you.
just a
Let's see what.
question.
Oh, sorry. Oh my gosh, Masa, I see you're talking, but I can't hear you. I think I messed up my headphone situation. One
Oh,
sec. Yeah. Okay. Yeah. Go for it.
no, I was wondering because I remember you once presented a rapid fire on angioedema, which also caused like epigastric pain and ascites, and I was just wondering if it would also cause like this
Yeah.
lower leg swelling. I know she's not on any ACE inhibitors, but
Yeah.
just a thought.
Yeah, it's a fantastic thought. I will tell you that there are two cardinal rules of angioedema. The first, it tends to be focal, and the second is it tends to be self-limited. And so it's a really powerful thing to see when somebody has focal self-limited swelling to think of angioedema. I think this patient has broken too many of those rules in that this is now a sustained process and it is widespread. And you can certainly get multifocal presentations of angioedema in three different spots, but for her to be so symmetric, face, legs, and for it to last this long, I think probably pushes us away from that space.
Thank you.
Yeah, great question. All right, Shreya, Mike to you.
Such a great discussion. Yeah, moving on to vitals. She was afebrile. Blood pressure was 160 by 92. Pulse rate was 112. Respiratory rate was 24. BMI was 32. On physical examination, she was conscious and oriented. HENT were all normal except pallor and edema in both legs up to knee. Abdomen was soft, non-tender, bowel sounds present. On chest examination, equal air entry with decreased bilateral basal crypts, wheezing in left basal zone as well. On CVS S1, S2 hard, no murmur, and neuro and MSK examination were all normal. And I'm going to stop here for the discussion.
Masa, I think maybe as is true in real life, you hear this facial puffiness, and then I think it's either underwhelming or underappreciated on the physical exam. And so I'm really curious, are you going back to square one and sort of like solving this problem without the facial puffiness, or are you saying, maybe because she's feeling it, I'm inclined to use that as a clue? What do you think?
Ravi, I'm so sorry to interrupt. I missed one point. Everybody might be feeling confused with the last line of HPI. When we asked her about her bowel and bladder habits, she said that I'm not able to defecate and I'm not able to urinate as much as well. But when we did examination and while on the hospital course, she was not found to be oliguric. So yeah, I wanted to clarify that.
Okay, that's very helpful. Thank you, Shreya. Yeah, Masa.
So, is there like no facial edema on examination? Is that what you're saying?
No. Facial edema was not very appreciated, but there was
Okay.
bilateral leg edema to knee.
Okay, so she like noticed it maybe, and then like now it's not there anymore.
Yeah, I'll give you a real light insight, Masa. When you ask patients leading questions, like when patients come in with leg swelling and you're like, oh, could you have kidney disease? You're like, hey, do you have facial swelling? And the patient's like, yeah, I think so. If it doesn't feel right. But I think something,
Mm,
as I think you were there yesterday when I was, or 2 days ago when I was sharing a rapid fire about asking patients leading questions, like, hey, with
mm,
this patient with the neck mass, hey, are you short of breath? And I wasn't until you asked me, but I am now, and I think so it's very, very common for us if we ask very close-ended questions on a review of systems that patients might grasp at them. And so you constantly have to ask yourself what's real and what's not. And
yeah.
just because you see something it may not be real, it may be chronic or long-standing. And just because somebody reports something doesn't mean it's there. So that's the constant struggle with what is the actual data. And so yeah, I'm curious what your instinct is telling you is to sort of use the history or use the exam for the facial puffiness. What do you think?
Okay, so in this case, I think I would go back to square one just to make sure we don't miss anything. Um, and she's having some basal crackles and wheezing. Like, I definitely don't want to miss like a heart failure. And then also with the pallor, like, could this be like a high output heart failure on top of like what she already has? Um, her blood pressure's quite high, which she's not really compliant to her medications, um, but could also be like um, a primary and then a secondary on top if it was renal related. Yeah, that's what I'm thinking.
Yeah, I think that this case is such a beautiful illustration of real life where we try to make progress on the main three organs. And the truth is, I think we need more objective data because there's no consistent theme emerging. This is not a patient with orthopnea, PND, leg swelling, and bilateral crackles that would be evocative of heart failure. This is not a patient with hyperbilirubinemia, asterixis, caput medusa that would be evocative of cirrhosis. And this is not a patient who has facial puffiness, marked hypertension, as would be evocative of renal disease. So I think
Mm-hmm.
the question is, does she have an unusual presentation of any of those three things? Does she have a combination of those three things? Or does she have none of those three things and has something rare and esoteric? And I think ultimately the biggest mistake to make here is to try to force yourself in a specific bucket. And I really admire what you did. You're like, I'm not going to use the facial edema to anchor here. I'm going to go back and see what progress I can make otherwise. And I'm right there with you. I couldn't have said it any better.
Yeah, so then in this case, we would need like an echo, chest X-ray, ECG, some renal function tests, and then liver enzymes. Those might help us move forward.
100%. I couldn't agree more. I feel like if you ask me what two tests I'm really itching for, it's an albumin and a TSH because the
Mm-hmm.
albumin really helps you capture a lot of liver disease, a lot of kidney disease. The TSH helps you capture the rare but real possibility of thyroid disease. And then, of course, sorry, I should have mentioned the BNP as well. I think those three tests are probably the queens of our next evaluation, and then we can filter through the data beyond those. But yeah, I think
Mm-hmm.
definitely need a laboratory assessment. Um, yeah, a lot of
You
time.
lagged.
Say that again.
You lagged for like the last 5 seconds.
Oh, sorry. Yeah, TSH, BNP, and albumin are my three favorite tests that I think will help in this case.
Okay, sounds good.
Shreya, this is very, very sweet indeed. I'm really curious if the glucose is going to be high because we can tie that into many cases in this case. But like to you.
Awesome discussion. Okay, so I'm gonna get some labs now. So CBC at hemoglobin is 9.5 with MCB 71. WBC is 8.5, neutrophil 78, and lymphocyte 11. Platelet is 108, which is low. BUN is 31, creatinine 1.5, sodium 139, potassium 3.5, chloride 105, calcium 7.9, phosphorus 2.1, PT was 19, PTT 13, INR 1.7, and retic count was 1.5. So I'm going to take a brief pause and see what you guys think about this.
Masa, do you notice what she did? She's a very astute presenter. She gave us none of the three labs that we were dying for. No albumin, no TSH, and no BNP. This is so hard. But we got some helpful data. What do you think about it?
Okay, just to make sure I'm looking at this correctly. So the hemoglobin is low, platelets are low, MCV is low, right?
Yes.
Hmm. Okay, so hmm. Yeah, okay, Sana mentioned to get some iron studies. I agree with that. Um, but I don't know, I don't know where to go from there.
Can I share a piece of advice with you? I
Mm-hmm.
think what you're doing is you're trying to put it together, right?
Mm,
But I think when you get data that doesn't quite line up, my advice is step back.
okay.
So when you step back and just think about microcytic anemia in general, what thoughts does that generate?
Okay, microcytic
Yeah,
anemia, iron deficiency anemia, thalassemia,
excellent.
and then things like sideroblastic anemia.
Exactly.
Yeah.
And I think iron deficiency and thalassemia are by far the most common. So if you had access to a prior CBC, how might a prior CBC help you have a pretest probability of which is going on?
If if it's thalassemia, then it would be there for a long time. Whereas if it's iron deficiency anemia, then you might not see it on all the previous
Exactly.
CBCs.
Yeah, the main distinction between iron deficiency and thalassemia is the iron deficiency is acquired and thalassemia is hereditary and long-standing. And so if you had access to prior data, that would be very powerful. But I think if you were to say which is more morbid, I think assuming iron deficiency is probably a better idea because iron deficiency is an acquired dynamic progressive disease that can get worse and worse and worse much faster than thalassemia. Now, it doesn't have to be the case. If you have iron deficiency from a bleeding that is stable, like menorrhagia, it doesn't mean that you're going to get into serious trouble, but it can mean that your bleeding may become much faster or from being more serious. So if you see iron deficiency in the context, if you're thinking about iron deficiency and you go back to the HPI, are there any aspects of the HPI that might cause some concern when you have a microcytic anemia for you?
Yeah, probably the epigastric pain and her history of
Yeah.
gastric ulcers. So she could be having like a slow bleed there.
Yeah. Yeah, precisely. I think, whenever you have any gastrointestinal history in the context of microcytic anemia, you start to worry that that microcytic anemia represents iron deficiency from chronic GI blood loss. And she has both upper and lower gastrointestinal symptoms with constipation, inability to defecate, and struggling to defecate, and with nausea and vomiting. So for me, I'm really wondering, is the patient having luminal GI issues outside of the vessels? And so what happened in my mind, Masa, is I think if we go back to like, we know her vessels are unhappy, she's swollen. We don't know if she has anything outside of volume in her abdomen. I think with the presence of microcytic, presumably iron deficiency, a sequence of events could unfold such that we're getting signal that she's bleeding in her GI tract. And bleeding in the GI tract cannot be attributed to a volume issue alone. And so if we go back to that initial thread of concern, that thread of concern that she has something outside her vessels has been verified a little bit. This is with the assumption, of course, that this is iron deficiency because it could be thalassemia, in which case it's a long-standing unrelated issue a long-standing and likely unrelated issue. So yeah, this
Mm-hmm.
is a little bit of like we weren't expecting that. Is it true and unrelated from thalassemia? Does it give us a signal into iron deficiency, which we have to incorporate into a volume overload problem? So I agree with you. It's hard to make progress because I think what it is it's not a clue that helps you unravel the picture you're seeing. It's a clue that you're like, I wasn't expecting, so now I have to bring them in together. So instead of being able to walk in a straight line, I think now you have to carry more objects with you. And it feels a little bit more burdensome, but it's way, way worse than dropping an object, forgetting that it's a clue, and just pretending like you can go in a straight line. So yeah, I felt that burden of, oh gosh, this case is a little bit more complex than I think first glance. But I think acknowledging that is really key and not force functioning progress, and rather just like saying, now is the time to have a cup of chai with Shreya and really think through this, you know?
Mm-hmm. And then what do you make of the platelets, or do you kind of keep
Yeah.
that aside for now?
See that's such a fantastic question, and the truth is that's very abnormal, and I don't know what to do with it quite yet. I think we should carry it along. I don't
Mm-hmm.
get any immediate hits on its relevance right now, And the only reason the microcytic anemia is relevant is because of her GI symptoms. It's also true that so many patients with low-grade thrombocytopenia, like 108, have no definitive cause, just like patients with a sodium of 131 or 132. It's technically abnormal, but the rate of a specific diagnosis is low. So yeah, I think your point is very valid. We should bring that along with the journey, but I certainly can't make progress with it right now. It would be very different if Masa, if this patient had a TMA picture or had dengue, but we're solving an edema problem, and an edema problem in thrombocytopenia doesn't have a robust, easy overlap.
Yeah.
Yeah. All right, Shreya. Uh, we're in trouble here. Hopefully, we can get more clarity going forward.
Yeah, I wish, Ravi, we could have a cup of chai and discuss some case together.
Oh, no doubt about it someday.
Yeah, I'm gonna give some. Yeah, I'm gonna give some more labs. So BNP was 75, and blood sugar was normal as well. It was 97, and total bilirubin was 0.9, and direct 0.29. AST was 140, ALT was 60, ALP was 127, GGT was 143. Am I audible? I think
You
there's
glitched out
something
for
going
just a
wrong
few
with it.
seconds. Shreya, I think you're yeah, we got everything.
Okay.
By we, I mean Aaron got everything.
Okay, sure. So serum protein was 0.5, albumin was 2, globulin was 2.5, urinalysis was normal. And yeah, I hate to disappoint everyone. We have no imaging findings to display today. I don't know if it's a happy thing or sad thing. I have a mixed feeling for this because most of them were normal. ECG was normal. Chest X-ray is normal as well. In echo, ejection fraction was 40% with mild TR, and LA was dilated as well. I don't have an exact value of TSH, but it was normal. Yeah, I'm gonna take a brief pause and listen to your thoughts.
Amazing. Masa, I'll just give you a second to think it through, and I'll maybe try to summarize the data. So we have an AST of 144, an ALT of 60, a slightly elevated alk phos, an albumin that is very low at 2, um, but without any evidence of renal loss because her UA protein is low. A relatively normal EKG, an echo with what seems to be at her baseline with her reduced ejection fraction. And yeah, I think that's. Did I miss anything for you?
Yes, pretty much.
Awesome.
Wait, so is the albumin and total protein, are they normal?
Albumin is very low. Albumin is half
Okay.
what it should be, and the total protein has been reduced proportional. So the total protein is what you expect it to be because the albumin is low.
Okay. So we have a hypoalbuminemic process going on, which could be from nephrotic syndrome, like we were talking about earlier, or malabsorption, or what's it called? Like she's not eating enough. And then is the AST a bit elevated?
Yes, yeah. AST
Okay.
is like maybe 5 times the upper limit
Okay.
of normal, and the ALT is also a little bit elevated.
Okay. So we talked previously about how AST is like from more systemic rather than just like localized to the liver. So yeah, like I'm not really surprised by that. And then what else? Yeah, her echo seems to be like consistent with her past medical history. I wonder why she has the left atrial dilation, because I always think of that from mitral stenosis. But yeah, would love to know what else could be going on. And then also you previously mentioned that like if Shreya gave us a glucose, it would help us. And I was wondering like how that would be helpful.
Yeah, no, I think that so one, I think your analysis of both the AST and albumin is superb. And yeah, no, I think that many patients with diabetes cause kidney issues, heart issues, and liver issues. And so I think if you were hyperglycemic, that would be a complicating issue. Um, Amasa, back to that original sort of thought exercise, which is the theme of this case, is what helped you make more progress, the AST or the albumin?
Definitely the albumin.
Yeah, right. It was one of those three tests. The TSH normal,
Hmm.
BMI normal with the albumin is actually a hit.
Hmm.
And a hypoalbuminemia is a very productive clue for the workup of of edema because it helps you really prioritize liver, kidney, and then some rare things. And so here, the question is, does she have liver disease? And the answer is yeah. I mean, if you look at her AST and ALT, the answer is yes. So we'll have to put that aside and analyze it. Does she have renal disease? With her urinalysis showing no proteinuria, the probability of nephrotic syndrome is low, but a urinalysis can sometimes miss that, especially if the urine is very dilute. And so some people would recommend repeating the UA or getting a urine to a protein to creatinine ratio. So if we put the liver aside for a moment and ask ourselves, how do we approach hypoalbuminemia? I think um, the approach to hypoalbuminemia is very disappointing when somebody's very sick because albumin is a negative acute phase reactant. So, when people get sick for any reason, your body decides you don't need albumin right now. You need to focus on other proteins. And so that'll go down. And so one very common and understandable reason for this patient who is 80 has all these problems to have albumin low is that she has so many other problems, and this is just noise. If albumin is going to be signal, it's not going to be from nutrition because a really powerful study done in medical students who fasted and they tracked their albumin when they fast and took no intake, the albumin was completely maintained. So albumin is actually not a proxy of nutrition. It's a proxy of inflammation or impaired synthesis in the liver or loss in the kidney and other places. So if you're having a simplistic approach to hypoalbuminemia, the most common cause is diffuse whole body inflammation and a negative acute phase reactant. The second most common cause is severe advanced liver disease. And the last category is the least common, where you actively lose albumin that you synthesize through the kidney, through the GI tract, and through blood vessels, i.e., nephrotic syndrome, protein losing enteropathy, and vascular leak syndromes, respectively. And so here, where would I start? I think you have signal towards the liver. So the question is, shall we explore the liver next? And I think that's probably the wisest next step to do, especially in a patient who's having abdominal symptoms, especially in a patient who's having epigastric symptoms. But you took it a step further and you're like, this isn't just liver disease, this is AST predominant liver disease. And AST predominant liver disease can be a clue to the development of cirrhosis, which is an important thing to think about because patients with cirrhosis reverse their AST-ALT ratio and they start to have an AST predominance. And she's at risk for cirrhosis simply because of her BMI. You heard her that her BMI is 32, so she could have metabolic syndrome associated liver disease. So that's very, very plausible. And that's where the platelets come in, right? Because the platelets might signify that she has portal hypertension. And her anemia would be fitting for liver disease as well. The other possibility of her AST predominance outside of cirrhosis is the two S's, one of which you mentioned, a systemic disease. The other possibility is a substance, and the most commonly implicated substance is alcohol. But it turns out that amiodarone actually causes an AST predominant liver injury pattern. Ravi, who's here, presented a case of fulminant liver failure from IV amiodarone many, many moons back. But the moons may have come full circle with a patient with amiodarone. Whenever you see liver injury and amiodarone, you really have to scrutinize that. So um, I think albumin is a powerful clue, and in the context of risk factors for liver disease, the presence of thrombocytopenia, and liver injury, I wonder what the liver looks like. And that's probably what I would do next. Um, that was a lot of sort of putting things together, so I'm curious what questions you have or reflections you have on that.
No, I think, yeah, I kind of I focused on the kidney, but like now that you mentioned it, yeah, it's all coming together for sure. And then also with the AST and the liver involvement, could the heart failure also be like affecting that?
Totally. Many patients have multifactorial reasons to have edema. Absolutely. And she has HFrEF, you know. And there
Mm-hmm.
is one big counter argument to liver disease, and that counter argument is in her vital signs. As practice, do you want to try to spot that counter argument to liver disease on her vitals?
Hmm. I'm not sure. Is it the heart rate? No, actually, I don't know.
What do you expect the blood pressure to be in patients with advanced liver disease?
I'm not sure. Would
Let
it
me
be
ask you this.
low?
When you look at a patient's skin with liver disease, what things do you see on their skin at the surface?
Oh, dilated veins. Okay, so
Ooh.
low.
Dilated veins, huh? What happens to the blood pressure if all your veins and capillaries are dilated?
There's gonna be portal hypertension.
Yes, correct.
Okay, so would it be high?
What happens is Um, because of impaired processing of many vasoactive molecules, most famously nitric oxide, you get diffuse vasodilation. And so all your capillaries and arteries vasodilate, including ones on your skin, which you can literally like compress because they're so dilated. And so because your vessels are dilated, your blood pressure gets lower and lower and lower. So it's very unusual for patients with liver disease to have this degree of a high blood pressure. The problem
Okay.
is, though, that I mean, she has hypertension to begin with, so maybe this is her declaring herself by going better. Maybe her baseline is 200. Who knows? But that's you know, every case in medicine, there's always something that's a counter argument for sure. Even the most obvious of crimes committed outside of medicine, there's always something that actually counters the threat of proof. Nothing is certain here, and so. I think just to acknowledge that that's a thing against the liver. But yeah, we'll see how how the case evolves.
Okay, thank you.
Oh, for sure. All right, Shreya, what do you have next?
Yeah, I'm gonna give some more labs now. So we did stool routine and culture and occult as well, which were all negative, with no evidence of any pathogen, ova, or parasites. We also did an endoscopy uh, after keeping in mind her past endoscopic evidence of gastric ulcers. So we did endoscopy and we found that erythematous mucosa was present in gastric fundus and body, and there was some small esophageal varices as well. We also did ultrasonography of abdomen, and we found decreased liver span with irregular contour, portal hypertension suggestive from dilated portal veins. There was mild splenomegaly and moderate ascites. I'm going to stop here and listen to what you think now.
Shreya, can I just ask real quick? Do you know how many? I'm just trying to plan one breakout room because there's so much learning in this case. Do you know how many aliquots until the final diagnosis?
One more aliquot and then final.
One.
And then final. Yes.
Okay, perfect. I think this is a great time, Masa. What do you think to just share your thoughts in a 5-minute breakout room and then we'll reconvene? Okay. All right, let me make it happen. All right, see you all in a few minutes. All right, welcome back. Okay, Masa, what wisdom did you accumulate from many wise people in your group?
Okay, so we talked about how this is definitely a picture of cirrhosis because of many reasons, whether it's the esophageal varices, the splenomegaly. I mean, on the ultrasound read, it does say portal hypertension, and then also the decreased liver span. So, like, that's all pointing towards cirrhosis. So, we were trying to figure out what the cause is. The stool culture is negative, which moves us away from parasites. And I was thinking of entamoeba, which can like affect the GI tract and the liver as well. But then also we talked about her BMI, which is elevated, so it could be non-alcoholic fatty liver disease that caused cirrhosis. We also mentioned some viral illnesses like Hep B and Hep C that can develop into cirrhosis. Hemon mentioned Budd-Chiari. I don't know much about that, but it was mentioned. But yeah, that's basically it, as well as schistomeiosis.
Yeah, absolutely superb thoughts. I think just for the sake of, as I mentioned to you, I have to leave a little bit earlier today. So I will tell you reason 173 to show up here and present your cases and consider joining the Academy is that we have to reflect on this case because I will tell you the punchline. I'm not convinced she has cirrhosis. I'm convinced she has portal hypertension. And I think you made a very compelling argument that she has portal hypertension because she has varices, splenomegaly, ascites. Cirrhosis accounts for 90% of portal hypertension. The clue that portal hypertension is caused by cirrhosis is base rate, of course, it's so common. But then you see that the liver itself, in addition to blocking the flow of portal vein, the liver itself is unhappy. So let's make a list of proof that we have that the liver itself is unhappy. And it begins by seeing that there's liver enzyme elevations. And then that's where it ends. INR normal, bilirubin normal, mental status normal, blood pressure high. So what could she have that would be even reasonable to entertain is the idea that she actually has amiodarone-induced liver injury. And the spectrum of amiodarone-induced liver injury is acute liver failure, chronic liver disease, but also non-cirrhotic portal hypertension. Now, why is this hypothesis important? Is because a large fraction of amiodarone-induced liver disease will actually resolve or improve with amiodarone cessation. So by saying I'm not convinced she has cirrhosis, I don't mean to imply that it's not a very likely diagnosis because an older woman with a high BMI is at such high risk for metabolic-associated liver disease. However, the very real possibility of amiodarone-induced dysfunction and the reversibility should mean that we keep that as our first default hypothesis. Ultimately, those two things can coexist, right? You don't, one hypothesis doesn't leave you immune to the other one. But the actionable hypothesis is really to think about that possibility. And classically, amiodarone will present in a 2-to-1 AST to ALT pattern as well. So yeah, I think what progress can we make? So if you have all the resources at your disposal, a liver biopsy is actually the definitive way to tell. But increasingly, people are using fibroscans, which are tools that allow you to measure the liver stiffness, which is a proxy of how much fibrosis and therefore cirrhosis the liver has. So Masah, we've definitively pinned the liver. There was ascites in the context of lower extremity edema. And when you see that in the context of liver enzyme abnormalities, you really have to affect the liver. And we've understood what the liver disease is. It's with liver disease with portal hypertension. The vast majority of liver disease with portal hypertension is in fact cirrhosis, but most people with cirrhosis have other evidence of cirrhosis that prove that the liver itself is unhappy through pulmonary erythema, hyperestrogenemia, high INR, high bilirubin. So she could have early cirrhosis or cryptic cirrhosis, but she has a reason to have non-cirrhotic portal hypertension, which is treatable and modifiable. And so I would put my energy in that. But I understand that her amiodarone may be crucial for her heart, and we may not be able to do anything about it. But I think entertaining it is really important. Any questions or reflections on that?
There's a lot to think about. Because I remember, I think the second case I presented was like a drug-induced liver injury from, if I'm remembering, it was cefuroxime or ceftriaxone. I gotta go back and look. And I think it was also similar labs, but the only thing is that patient had like really prominent jaundice. And yeah, I was just wondering why this patient doesn't have jaundice if like their liver is affected.
Yeah, I think it just goes to show you the heterogeneity of, the liver is a very complicated thing. And so you can have horrific liver disease without jaundice. And you can have such severe drug-induced liver injury that the only thing you have is jaundice. And so I think it just shows you the complexity of what the liver is. It's made of so many different things and parts. And I think also illustrates the complexity at which drugs cause liver injury. There's drug-induced direct hepatotoxicity. There's drug-induced steatohepatitis, which is what amiodarone does. So I think the lay of the land is very, very complex. When you zoom in, you realize there's many different complexities. But who knows? Maybe we're completely off track. Shreya, what is your final aliquot here?
Yeah, I just have one finding, and then
Yes, go ahead.
I'll just hear your thoughts, and then I'll say the final diagnosis. Yeah. So we did ascitic tapping, and total count was 55. Protein was 0.5, albumin was 0.3, glucose was 80, and culture QOH showed no fungal pathogen. SAG was done, which was SAG was found to be 1.6. Do you want to say something about this, or should I just say the diagnosis and the
Yeah.
treatment?
I think, Masa, what do you think about the elevated SAT? What does that do for you?
Oh God, this concept always confuses me, but let me think about that. So elevated SAG means that there is increased serum albumin compared to like albumin in the
Yes, the fluid.
I just remember that because there's like no inflammation, and so like the albumin can't pass through because yeah,
Exactly.
something like that.
So the question for you is the ascites from leak of the portal vein or from too much pressure in the portal vein?
Too much pressure.
Exactly. So this confirms the presence of portal hypertension. So now the question is it cirrhotic portal hypertension or non-cirrhotic portal hypertension? And I think that is probably unanswerable definitively without a liver biopsy. But we'll see what I think it just confirms that we are on the right track to say, is this cirrhosis? Is this non-cirrhotic portal hypertension from amiodarone, or is this actually a combination of both things? But yeah, I think Shreya has kindly said, hey, don't worry, you're on the right track. All right, Shreya, how did you all settle this case?
Yeah, so unfortunately, I don't have any diagnostic investigations. Uh, and so the diagnosis we did was decompensated liver disease with ascites without SPP, and patient was started on lactulose, carvedilol, and spironolactone, and the treatment course was good. Response to treatment was good. So yeah, the reason I presented this case out of all complicated case I have in my list, because when the patient presented, we were just like everybody in this session, and I knew the discussion is going to be great because we were all revolving around what is it? Is it liver? Is it heart failure? Is it nephrotic syndrome? Is it even malignancy? And because mainly because we didn't find anything in examination except chest findings, and patient was obese. We couldn't appreciate the ascites in the patient. So until the diagnostic workup started coming back positive, pointing towards liver, and it's mainly because the response to treatment was good. So I thought it would be a really warm discussion for everyone, and it would be nice to revisit all those topics and go through it together.
Yeah, Shreya, I think this is a very, very illuminating case and goes to show you how difficult it is to find. This is a bread and butter case. And I think I'm so grateful whenever somebody presents a bread and butter case because it shows you that diagnosing liver disease is very difficult and very hard and can be easily camouflaged for many reasons. And so I think the journey that you took us on to make what is a very common diagnosis is so productive. I enjoy this way more than diagnosing Castleman's or Poem syndrome and whatnot. And Masa, I thought your reflections were absolutely superb, both in terms of how much progress you can make, but also your sort of metacognitive reasoning about what's through how helpful, whatnot, and then also just your authenticity about when you don't know something. It was so cool at the end to see you go back, be like, okay, the albumin is high in the blood, it's low in the ascites. How can I like deduce that? I find those moments really, really precious. unfortunately, I have to hop off. So I will make Vinny our host because he's doing teaching points. So Vinny, feel free to end the meeting when you're done, and I cannot wait to check out your teaching on YouTube. I just want to say one growth point for me. There's many. This case I'll probably end up reading about for hours, honestly. But I wanted to impart with you the idea that if you're solving an edema problem, uh, I will use this case to remind me that edema plus thrombocytopenia equals portal hypertension. And Masa, if you remember when I said to you, I'm not really sure how to take advantage of this platelet count. And this case is teaching me that if you have low platelets with edema, you really should go looking for liver disease. And I find that to be a very powerful lesson. I've seen it many times, but I didn't see it enough and reflect on it to fully upload it in my mind. So this is my biggest takeaway. I'm sure many people will have others. I can't wait to reflect with you all about them. All right. Vinny, the mic is yours, my friend. See you all later.
Bye.
Oh,
Thank you.
yeah, well, so thank you so much for Massa discussing the case and for your phenomenal presentation. So, yeah, just a quick recap. So, we started with an 8-year female patient that we initially presented with abdominal pain, and we can have like different approaches for investigating possible etiologies, but like the main one and more intuitive would be the anatomical approach. So you can divide like right upper quadrant, epigastric pain, and so on, and their etiologies. Further, like in the case, later in the case, the patient also had like presumed facial edema, and then we discussed it about the possibility of being gravity dependent, if it can affect the lips. It is morning, it's more present in the morning, and if this is periorbital, acute, and chronic, and try to differentiate between all kind of nephrotic syndrome and angioedema. And angioedema would be more local and limited kind of facial edema, but in the end, the patient didn't have it. So we then started to think about more kind of a clinical a nephrotic syndrome picture that it is important to remember like the triad that would be like proteinuria with more than 3.5 grams a day alongside hypoalbuminemia, edema, and also hyperlipidemia, and it's mostly related to a decrease in plasma pressure due to an albumin loss. So we also saw that some important tests that would be feasible and coherent for this patient would be and the TSA, the BNP, and the albumin, and being the albumin and negative acute phase reactant, and so you can have like regards to possible etiologies for a low albumin. It is they are like decreased production, increased loss, dilution, and increased catabolism, and mainly it reflects a chronic inflammation panorama. And also the patient had like a microcytic anemia. We discussed about possible etiology such as iron deficiency anemia, thalassemia, and it's important to access TIBC, the transferrin saturation pattern, ferritin, and those reflects the iron profile of the patient. And then we further saw that the patient had a liver injury, a weakened divide liver injury in cholestatic pattern and hepatocellular pattern. With in this case, the patient had a AST predominant disease, and this is a clue for cirrhosis secondary, maybe to metabolic associated liver disease, alcohol, or even amiodarone-induced liver failure. The patient was exposed to this medication. And we also saw that the patient was not hypotensive, and we saw the pathophysiology about it, that about the nitric oxide promoting diffuse vasodilation. Well, in the end, we it was tricky, and we maybe can think about the possibility of having the amiodarone induce a liver failure. And in this case, like the CT would reveal a hyperdense liver due to iodine deposition. This is kind of almost pathognomonic, and you can just stop amiodarone and proceed with supportive care. So yeah, that was a phenomenal session. Well, thank you so much for attending it, and hopefully see you guys tomorrow. Bye. Have a nice day.